Hey, BC here from BC Nephro. Today, I want to talk about what to do with a kidney transplant patient, how to think about managing a kidney transplant patient who shows up at a community hospital. So there's two things that are important, in my opinion, to think about. First is the triage of these patients, and the second is issues regarding immunosuppression. So when we're talking about the triage of these patients, there's certain patients that really shouldn't be at the community hospital at all. They should be sent straight to the transplant center. There's certain patients that can be co-managed by the nephrologist at the community hospital in consultation with the transplant nephrologist. And there's certain patients that are very stable, remote transplant, that can just be monitored safely by the nephrologist at the community hospital. So how to figure that out? How do we triage those things? So the things to really think about are initially the first 3 months. The first 3 months is when there can be surgical issues, surgical complications need to be managed by the transplant surgeon. So if someone's within 3 months of transplant, they should be sent down to the transplant center, the transplant surgical service. There's complications can be related to wound dehiscence. There can be lymphoceles, which are fluid collections around the transplant. There can be problems with the ureteral anastomosis, other post-op issues. Those patients, there should be direct communication with the transplant surgical service. Then the second thing to think about is the risk for acute rejection is highest in the first year of the transplant. So acute rejection really should be managed at the transplant center. So in my opinion, patients within the first year, 3 to 12 months, if they have acute kidney injury, they should be triaged to the transplant center because there's a possibility that this acute kidney injury is related to acute rejection. The second thing has to do with immunosuppression management. So really there's three main types of immunosuppression. About half the transplant centers use all three categories, and about half, or maybe a little bit more, half than 60% use a 2 immunosuppressive regimen. They use a steroid-free 2 immunosuppression drug regimen. So the cornerstone for both of these regimens is a class of drugs called calcineurin inhibitors. Mainly we see here tacrolimus, occasionally see cyclosporin, which is an older drug. I'm going to talk, the second drug is an antimetabolite, which is mycophenolate, and the third drug is steroids for the centers that use a 3-drug regimen. I'm going to talk the most about tacrolimus. There's many issues regarding this drug. It's the most common drug used. So first of all, things to know about tacrolimus. It comes in an immediate release and an extended release preparation. Most common name for the immediate release preparation is Prograf. The most common name for the extended release preparation is Envarsus. Now, the first thing to know is that the immediate release is a Q12 drug. The extended release is a Q24-hour drug. The immediate release is not a BID drug. It's a Q12, typically given 9 a.m., 9 p.m. The 24-hour drug is typically given at 9 a.m. Next thing to know, the dose conversion for these is not 1-to-1. So if you wanted the dose conversion, let's say the formulary doesn't have Envarsus, the extended release is 80% of the total daily dose of the immediate release. So for example, if someone's on, let's say Envarsus 5 milligrams a day, you wouldn't give short-acting tacrolimus 2.5 Q12. You would maybe give 3 milligrams Q12. That's approximately that 80% dose conversion. The third thing to know is about really at community hospitals. Really, this IV formulation it's tricky. It's not used, in my opinion, should not be used. So this tacrolimus needs to be given, and it needs to be given enterally. It really should not be held for any reason, with the exception if the levels are toxic and you need to wait till the levels get down. But otherwise, the patient's MPO, they still need to get the drug. So how do they get the drug if they're MPO, post-op, or some things? Well, one thing is to get a tube in, a liquid formulation. If that's not possible, The other way is to take the contents of the capsule, open the capsule, put the contents sublingually, and that sublingually is absorbed. The next thing has to do with levels. So a typical tacrolimus trough level is between 5 and 7. That's the target level. It's a trough level. In my opinion, patients know how to do this as an outpatient. They take their drug at 9 p.m., they go to the lab at 8 a.m., they have their blood draw, and then they take the medication after that. In the hospital, I think you're more likely to get some inaccuracies, and you need to be careful about that. So one inaccuracy is that the lab comes around after the med is drawn. So it's not a trough, it's actually a peak. And the second thing is really, is it somewhere close to 12 hours? Because in the hospital, maybe the med is prescribed at 9 p.m., maybe it's given at 9:30 or 10 p.m. There's an hour window for nursing there. And then the lab doesn't come around maybe at 8 or 9 a.m. Maybe they come around at 4:30 or 5. So we might be looking at like a 7-hour trough and not a 12-hour trough. And making dose adjustments based on this can be making dose adjustments based on really misleading information. Now, if there's a reason to think that the tacrolimus is high, then definitely you need to check the levels. Now, what are the reasons why you might think that tacrolimus is high? So the first thing is if there's evidence of toxicity. Toxicity may manifest as acute kidney injury. The tacrolimus high levels can cause vasoconstriction into the afferent arteriole, into the kidney, acute kidney injury. And then there's neurologic side effects, tremors, and things like this. That's when you think about it. The other reason to think about it is if you're using a drug that can interfere with the levels. And in my opinion, we should try to avoid these drugs in most, if not all cases, at the community hospital. So the main drugs, there's some drugs that raise the levels through P450, there's some that lower the levels, but the most common ones I see are the non-dihydropyridine calcium channel blockers, diltiazem, cardizem drip, that will raise the level, and azole antifungals, posaconazole, voriconazole, to a lesser extent, fluconazole, will raise levels. So these drugs should be avoided, and if because of this potential. And if they really have to be given, there's no other alternative, then you really need to think about talking to the transplant nephrologist about preemptively cutting the dose, monitoring the levels very closely. Now, the second drug I'm going to talk about is mycophenolate, which is in the 2-drug regimen and in the 3-drug regimen as well. So this is the antimetabolite. This is the medication that actually is the prime candidate for being held in situations where there's an infection and you need to decrease the amount of immunosuppression. And this has become more commonplace with the COVID pandemic, transplant patients hospitalized with severe COVID. So this can be held, in my opinion, well, first of all, holding it should be done in consultation with the transplant nephrologist at the transplant center. And second of all, in my opinion, patients need to be on at least 2 drugs. So if they're on the 3-drug regimen and you end up holding the mycophenolate, all right, they're still on 2 drugs, they're still on the tacrolimus, they're still on the prednisone. If patients are on a 2-drug regimen, steroid-free regimen, well then you hold the mycophenolate, then they're only on 1 drug. In my opinion, 1 drug, tacrolimus, is not enough for a kidney transplant. You might be able to get away with it, but we don't want to get away with things when we're managing. We want to make sure that their kidney, we don't screw up their kidney, essentially. So in those cases, when the mycophenolate is held, they're on tacrolimus, add steroids, add a low dose of prednisone while the mycophenolate is held. They recover, they're well enough to go back on the mycophenolate. Prednisone can be stopped at that point. So these are my opinions about how transplant patients, kidney transplant patients, should be thought about, should be managed when they show up at the community hospital. And the important aspects are how to think about triage, appropriate triage, and how to think about managing the immunosuppression. Thanks for being here. Welcome to BC Nephro. You can learn more at bcnephro.com.